Thank you very much, everyone, again for joining. As I mentioned, this conference is being recorded and will be hosted on our website. I am thrilled to introduce Dr. Clifford Kashtan with the University of Minnesota Medical School for our first Ask the Expert series. And without further ado, I am going to hand it over to Dr. Kashtan.
Okay, thanks, Gina. I am trying to go to the third, there we go. Okay, so I titled this webinar Alport Syndrome Basics. My plan is to cover the genetics and the clinical features and the treatment of Alport syndrome in today's talk. It's an overview, and upcoming webinars will give us the opportunity to go into much more depth on different topics related to Alport syndrome, but you can think of today's presentation as the what of Alport syndrome. I'm not going to talk so much about the why. I'm just going to talk about what the disease is and how it's transmitted in families, and our current attempts to treat Alport syndrome. The talk should last about a half an hour and hopefully leave plenty of time for questions. First, I'm going to start with some disclosures. I'm a site investigator for the Athena study that's sponsored by Regulus Therapeutics. I've served as a consultant for Regulus, also for Roche and RAAS. We've had research funding from Novartis Institute for Biomedical Research, and the Alport Syndrome Treatments and Outcomes Registry is generously supported by the Alport Syndrome Foundation and the Schumann and Peterson families. So I'm going to start with a definition of Alport syndrome. It's an inherited disorder of the kidney, the inner ear or cochlea, and the eye that results from genetic mutations affecting the collagen 4 alpha 345 protein network of basement membranes. And basically, that's the last you're going to hear about the alpha 345 collagen 4 protein network in this webinar, because that's a big topic all by itself, and I think would be a good topic for a future webinar. The main features of Alport syndrome in the kidney are blood in the urine, or hematuria, protein in the urine, or proteinuria, and gradual loss of kidney function that often leads to end-stage renal disease, or what's called ESRD. The effects of Alport syndrome in the inner ear are to cause sensory neural hearing loss in many people with the disorder. And the major changes in the eye are a change in the shape of the lens called anterior lenticonus, and a change in the pigmentation of the retina, which causes what's known as a maculopathy. And I'll describe the eye changes toward the end of the talk. The exact prevalence of Alport syndrome in the United States, how many people in the U.S. have Alport syndrome, is not precisely known, but it's less than 200,000 people, which makes Alport syndrome in the eyes of the Food and Drug Administration an orphan disease. And Alport syndrome is the most common disease of the filtering units of the kidney, called glomeruli. It's caused by an abnormality in a single gene. So it's the most common monogenic glomerular disorder, meaning a person has a mutation in one gene that leads to Alport syndrome. Alport syndrome has a long history. dating back to the early part of the 20th century. And this slide goes through the history of Alport syndrome. Can you see my cursor? Hello?
Yes, we can see it.
Okay, great. So in the late 1800s and early part of the 20th century, British physicians described families with kidney disease with symptoms of including blood in the urine, protein in the urine, and kidney failure associated with deafness. And in 1927, A. Cecil Alport, whose picture is shown here, wrote a paper combining all of the features of Alport syndrome, except for the eye changes, into a single condition. And so Alport syndrome has carried his name ever since, or basically ever since the 1950s. Physicians understood very little about Alport syndrome until the 1960s, when electron microscopy began to be applied to the evaluation of kidney biopsy material. And that's when pathologists noted unique changes in the walls of the capillaries, or tiny blood vessels that make up glomeruli, the filtering units of the kidney. And this electron micrograph shows the classic appearance of the glomerular capillary wall in a man with Alport syndrome. By the 1980s, we knew that Alport syndrome was a disease of the major collagen of capillary walls called collagen 4. And in 1990, the first gene associated with Alport syndrome was identified. That was the COL4A5 gene on the X chromosome. From 1995 to today, well over 1,000 mutations in the COL4A5 gene have been found in people with the X-linked form of Alport syndrome. And in the 1980s, two additional collagen 4 genes called COL4A3 and COL4A4 were identified. And shortly thereafter, mutations in COL4A3 or COL4A4 were identified in people with the autosomal recessive form of Alport syndrome, the autosomal dominant form of Alport syndrome, and a condition called thin basement membrane nephropathy, which I think is a subtype of Alport syndrome. And then finally, since 2000, animal models, particularly mouse models of Alport syndrome, have been used extensively to understand the biology of Alport syndrome and identify targets for treatment. And studies in both animals and people, which I'll talk about in a little bit, have shown that Alport syndrome is a treatable disease. So mutations in 3 genes can cause Alport syndrome. As I said before, there's the COL4A5 gene on the X chromosome. Mutations in this gene cause the X-linked form of Alport syndrome. And this is the most common type of Alport syndrome and accounts for about 65% of people with the disease. The 2 other genes for Alport syndrome are COL4A3 and COL4A4. These genes are involved in the autosomal forms of Alport syndrome. Each person has 2 copies of these genes. If there's mutations in both copies of COL4A3 or both copies of COL4A4, that causes autosomal recessive Alport syndrome, and that accounts for about 15% of people with Alport syndrome. If there's a mutation in just one copy of COL4A3 or COL4A4, that causes autosomal dominant Alport syndrome, which accounts for about 20% of people with Alport syndrome. Now, the next few slides, which I borrowed from the Alport Syndrome Foundation website, describe the inheritance of the different types of Alport syndrome in a family. So in this case, a father has X-linked Alport syndrome. He'll pass his Y chromosome, which is what makes him a male, to his sons. They'll get their X chromosome from their unaffected mother, so they will not have Alport syndrome. On the other hand, all of his daughters will inherit his X chromosome, and they'll have Alport syndrome. In this example, it's the mother who has X-linked Alport syndrome. And with each pregnancy, whether it's a boy or a girl, there'll be a 50-50 chance that the child will inherit her abnormal X chromosome and therefore have Alport syndrome. Of course, there's a 50-50 chance the child will inherit the normal X chromosome from his mother or her mother, and the child will be unaffected. This slide shows autosomal recessive Alport syndrome. And in this example, big R is the normal copy of COL4A3 or COL4A4, and the little r is the mutant copy. Each parent has one normal copy and one mutant copy of the affected gene. And so they're what are called heterozygotes, which is actually a more accurate term than carrier, but that's a discussion for another webinar. Anyway, with each pregnancy, there's a 25% or 1 out of 4 chance that the child will inherit a mutant chromosome from his mother and a mutant chromosome from his father and have autosomal recessive Alport syndrome. There's also a 1 out of 4 chance the child will inherit both normal copies of the chromosome that's affected, and the child will be unaffected, and a 50% chance that the child will inherit one mutant chromosome and also be heterozygous or heterozygote for Alport syndrome. And then in this last example, we have autosomal dominant Alport syndrome. Here we have the mutant gene is a capital D. The normal gene is small d. With each child has a 50% chance of inheriting the mutant gene, and because it's dominant, will be affected with Alport syndrome. So that's a brief discussion of the genetics of Alport syndrome. Gina, I'm just noticing that animation doesn't seem to work here. Is that true?
It should be working. I uploaded your presentation, but there may be a challenge with it. Is there a specific thing that you needed?
Well, this is an incomplete slide as it's shown here right now. I don't know which of these icons is animation. not that one, not that one. Well, that's erasing.
There you go.
No, that's just a cursor.
Okay.
Well, what this slide is supposed to show is that Alport syndrome is a disease that occurs in stages. So it's a disease, as shown here, that progresses to end-stage renal disease. Forward to the next slide and it may show. No. Unfortunately, not. No, it just goes to the next slide. No. Sorry about that. Do people like this full screen view better? Is this a better view?
However, it's best for you, Dr. Kashtan.
Okay. Well, this is fine. But so the phase 1 is hematuria. Phase 2, which is supposed to be here, is begins when there's elevated levels of protein in the urine, or proteinuria. The kidney function is still normal. Phase 3 is a period where kidney function starts to decline, and phase 4 is end-stage renal disease. And basically, everyone with Alport syndrome goes through the same progression, although in some people, the disease really stays in the hematuria phase for decades. Whereas in other people, as you can see here, the transition to phase 2 occurs relatively early in life. And the challenge of treating the kidney disease of Alport syndrome is to slow down the rate at which the disease passes through the different stages of the disease. So one of the consequences of this sort of phasic characteristic of Alport syndrome is that children who present with the disease have different features than adults who, or people who are not diagnosed until they reach adulthood. So hematuria, or blood in the urine, is the major feature of the disease in children. Children with Alport syndrome have microscopic hematuria, meaning you need to use a dipstick or a microscope to see the blood in the urine. But it's also fairly common for children to have gross hematuria, meaning hematuria you can see with the naked eye. So the urine looks brown or red. In many children, this is episodic. It comes and it goes. It's particularly maybe associated with infections like cold or gastroenteritis. And in some kids, the gross hematuria is almost constant. On the other hand, the amount of blood in the urine tends to decrease and never go away entirely as people get older. So adults are more likely to present with microscopic hematuria. Children with Alport syndrome at presentation, when they first see a doctor, often have normal levels of protein in the urine or only mildly elevated levels of protein in the urine, whereas adults can have a substantial proteinuria when they first are seen by physicians and suspected of having Alport syndrome. Blood pressure is typically normal in children with Alport syndrome, and it's often elevated in adults with Alport syndrome. Children usually have normal kidney function or glomerular filtration rate, whereas decreased glomerular filtration rate is very common in adults who present with Alport syndrome. Children at presentation usually have normal hearing or hearing loss that can only be picked up with an audiogram, whereas adults often have hearing loss at the time they're diagnosed with Alport syndrome. And the eye findings of Alport syndrome are usually absent in children, but they're not unusual in adults with Alport syndrome, whether they have the X-linked or the autosomal recessive form of Alport syndrome. This slide shows the probability of reaching end-stage renal disease, kidney failure where a person needs dialysis or transplant, in males with X-linked Alport syndrome who never received treatment, as well as females who never received treatment. So you can see about 50% of males with X-linked Alport syndrome reach ESRD by the age of 25. About 90% are by age 40 and nearly 100% by age 70 to 80. End-stage renal disease is less common in females with X-linked Alport syndrome, but it's still a significant risk. So by age 45, about 15% of women with X-linked Alport syndrome who haven't received any treatment have reached end-stage renal disease, and about 20 to 30% by age 60, and maybe as high as 40% by age 80 in the absence of any treatment. Women with X-linked Alport syndrome who develop proteinuria, elevated protein levels in the urine, have a significantly higher risk of eventually developing end-stage renal disease, and the same goes for hearing loss. If a woman with X-linked Alport syndrome develops hearing loss, she has a higher risk of developing end-stage renal disease. Now, a major difference between X-linked Alport syndrome and autosomal dominant Alport syndrome is that end-stage renal failure tends to occur later in life in people with autosomal dominant Alport syndrome. So, like I said before, about 50% of men with X-linked Alport syndrome reach ESRD by age 25, but it takes until about age 50 for 50% of men with autosomal dominant Alport syndrome to reach ESRD. And the same holds true for women with autosomal dominant Alport syndrome. This slide shows how nephrologists stage chronic kidney disease. So basically, everybody with Alport syndrome has chronic kidney disease stage 1 at some time in their lives. That just means they have normal kidney function. But if they have blood in the urine or they have protein in the urine, they have chronic kidney disease. So they have chronic kidney disease stage 1. Stage 2 is mild chronic kidney disease, where kidney function is about 60 to 90% of normal. Stage 3 is moderate chronic kidney disease, where kidney function is about 30 to 60% of normal. Stage 4 is severe chronic kidney disease, where kidney function is 15 to 30% of normal. And finally, end-stage renal disease is kidney function less than 15 to 20% of normal, and this is when people frequently need dialysis or kidney transplant. And the treatment of chronic kidney disease depends in part on the stage of chronic kidney disease that a person has reached. There are some standard approaches to treating chronic kidney disease that apply to people with Alport syndrome, such as salt restriction in those people who have elevated blood pressure, avoiding excessive protein intake. This applies to adults who've completed their growth, so they don't have as high a protein requirement as growing children and adolescents. Maintaining a normal blood sugar, dietary changes to reduce potassium and phosphorus intake if necessary, and then maintaining a healthy body weight. Treatment of elevated blood pressure is recommended in adults to keep the blood pressure under 130/80. For children, we start antihypertensive medication when blood pressure is greater than the 90th percentile. This is in patients with chronic kidney disease. Our target blood pressure would be the 50th percentile for age and height. Now, there are no FDA-approved treatments for Alport syndrome, but we commonly use angiotensin-converting enzyme inhibitors as off-label treatment for Alport syndrome, kidney disease, as well as other types of chronic kidney disease. So just briefly, the renin-angiotensin-aldosterone system, or what's people call the RAAS, is a hormone system that helps us maintain normal fluid balance and blood pressures and ensures optimal blood flow to the kidneys so they can perform at their optimal level. But this system becomes overactive in various types of chronic kidney disease and can promote scarring in the kidney, or what we call renal fibrosis. There are several different types of medication that can suppress an overactive RAAS, including angiotensin-converting enzyme inhibitors, or ACE inhibitors, that block the production of angiotensin II, the active form of angiotensin. Angiotensin receptor blockers, or ARBs, that block the action of angiotensin II, and aldosterone inhibitors that block the action of aldosterone. So, angiotensin-converting enzyme inhibitors, or ACE inhibitors, along with a variety of other treatments, have been tested in mice with Alport syndrome. And this graph shows the effect of the treatment on lifespan compared to untreated or placebo-treated animals. And in mice, we use lifespan as a measure of a significant effect on kidney function, because mice with end-stage renal disease die. They don't undergo dialysis or transplant. They die. So a treatment that significantly prolongs the life of an animal with a kidney disease is an effective treatment. So here you can see ramipril, which is an angiotensin-converting enzyme inhibitor, increased lifespan by 100%, so double the lifespan of mice with Alport syndrome compared to mice that received a placebo. And this effect was far greater than any other tested treatment so far, whether it was an angiotensin receptor blocker or amniotic fluid stem cells or other types of intervention. So far in mice, angiotensin-converting enzyme inhibition is the most effective treatment of Alport kidney disease. And this has also been shown in people with Alport syndrome. So in this study by Oliver Gross and his colleagues from Europe, men with Alport syndrome who started to receive an ACE inhibitor while they still had normal kidney function were compared to men with Alport syndrome who never received treatment. So the red line is no treatment. The green line is treatment while kidney function was still normal. So in the untreated men, they reached 50% reached end-stage renal disease by about age 25. In men who received treatment, starting when they still had normal kidney function, 50% ESRD was delayed until after age 40. So there was a benefit in this group of approximately 18 years. And treatment with an ACE inhibitor also delays end-stage renal disease in women with X-linked Alport syndrome and in men and women with autosomal dominant Alport syndrome. And so Alport heterozygous, people with mutation in one gene, one copy of a gene. So the consensus among people who study Alport syndrome is that ACE inhibitor therapy should begin in anyone with Alport syndrome who has proteinuria, which is defined as a urine protein creatinine ratio greater than 0.2. We recommend starting therapy earlier when the urine level of albumin is elevated, but the dipstick is still negative for protein, and that's called microalbuminuria. So once the microalbumin creatinine ratio is greater than 30, in boys with X-linked Alport syndrome who have a family history of early ESRD, meaning by age 30, or a COL4A5 mutation that's predicted to cause early ESRD. So these boys should start to receive treatment once they develop microalbuminuria. And the same holds true with boys and girls with autosomal recessive Alport syndrome. We haven't yet started to recommend treatment before there's microalbuminuria because basically out of safety concerns. But it's possible that sometime in the future we'll recommend moving the start of therapy back to an earlier stage in the disease. The goal of ACE inhibitor therapy is the maximal reduction in urine protein levels without significant adverse effects. But just because the urine protein levels remain elevated does not mean that the treatment isn't working. ACE inhibitors do lower urine protein levels in many people with chronic kidney disease, but they have effects beyond lowering urine protein. They have effects on the pathways that lead to scarring of the kidneys that are also beneficial and are probably active even if there's elevated levels of protein in the urine. So we continue therapy even if the urine protein levels are remaining elevated. So just a few more slides. So where are we with monitoring and treatment in 2017? So in Alport patients with hematuria who have normal urine albumin or protein levels, we recommend annual measurement of blood pressure, kidney function, urine albumin, and urine protein levels. Once patients develop microalbuminuria, we increase the frequency of monitoring to every 6 months, and we consider ACE inhibitor therapy for patients with severe genotypes, sensorineural hearing loss, or family history of end-stage renal disease before 30 years of age. If there's hematuria and proteinuria, people should receive an ACE inhibitor with the aim of minimizing proteinuria. And if there's progressive proteinuria despite an ACE inhibitor, we can consider add-on therapy, such as an angiotensin receptor blocker or an inhibitor of aldosterone. And then just a couple of final words about hearing loss and eye changes in Alport syndrome. So the risk of hearing loss in men with X-linked Alport syndrome is about 50% by age 15, about 75% by age 20, and nearly 100% by age 60. In women with X-linked Alport syndrome, the risk of hearing loss is about 20% by age 60. In autosomal recessive Alport syndrome, whether the child or the person is male or female, the frequency of hearing loss is similar to males with X-linked Alport syndrome. Hearing loss is unusual, but can occur in autosomal dominant Alport syndrome. The hearing loss in Alport syndrome is never congenital. It's not present at birth. The earliest we can typically pick up hearing loss by audiogram is around 5 or 6 years of age. The hearing loss is always bilateral, so it always affects both ears, although they can be unequally affected or asymmetrically affected. The important point is that even though hearing is affected, most people with Alport syndrome keep good speech discrimination, so they can tell the difference between different sounds of speech, unlike other forms of sensorineural hearing loss. So most people with Alport syndrome, hearing loss responds very well to amplification, that is hearing aids. And then some patients have associated tinnitus, or ringing in the ears. And sometimes that's quite severe, but fortunately that doesn't affect most people with Alport syndrome. We don't really know anything about treating the hearing loss of Alport syndrome other than with hearing aids at this point. We do recommend minimizing exposure to loud noise because mice with Alport syndrome seem to be more susceptible to noise-induced hearing loss than their normal counterparts. And then lastly, Alport syndrome can affect a number of different parts of the eye. The two most common abnormalities are anterior lenticonus, where the lens, the central portion of the lens bulges forward behind the cornea. This can cause a change in visual acuity that may need correction with glasses and can sometimes lead to cataract formation. The other common change is a change in the pigmentation or the coloring of the retina, with yellowish flecks around the focusing area of the retina, which is called the macula. And this rarely leads to changes in vision, whether it's visual acuity or color vision. Basically, about 20% of patients with X-linked Alport syndrome and autosomal recessive Alport syndrome develop lenticonus or the maculopathy, and these are rare problems in people with autosomal dominant Alport syndrome. So that's the end of the formal presentation.
Thank you. Thank you so much, Dr. Kashtan. If anyone has questions, you are welcome to ask them in the chat. We have a couple of questions that have already come in, and so I'll ask those, and then I will unmute the lines if anybody else has questions that you'd like to ask on the phone. One question that came in is there any research done where ARBs are more effective than ACE inhibitors or vice versa?
In mice with Alport syndrome, the ACE inhibitor was more effective than the ARB. There hasn't been a head-to-head comparison of ACE and versus ARB in people with Alport syndrome. We know that ARB can also lower urine protein levels in people with Alport syndrome. So I would say most nephrologists start with an ACE inhibitor. They may switch to an ARB if the patient has problems with lightheadedness, orthostatic hypotension, or cough. But most people start with an ACE inhibitor but may add an ARB in certain situations if proteinuria doesn't respond well to the ARB alone.
Great. The next question is, someone is being evaluated for lenticonus and possible keratosis by a corneal specialist. Do you feel someone familiar with AS specifically would be advised?
No. I think most people with Alport syndrome who have ocular signs or symptoms see ophthalmologists who don't have any particular interest in Alport syndrome, and there really aren't many of those. There's an ophthalmologist in Australia who's published probably more than anyone on the eye changes in Alport syndrome, but wouldn't be practical for most people to travel to Australia for their ophthalmologic care. So, it's important that, obviously, that a person with Alport syndrome seeing an ophthalmologist should inform the ophthalmologist about the disease, that they have the disease.
Great. Is it possible that COL45 mutation can be a milder case of familial hematuria and not Alport syndrome?
People with some people with COL4A5 mutations have relatively slowly progressive disease. So there are men with X-linked Alport syndrome who, are in their 60s and still don't need dialysis or transplant. In a future talk, I think that's something we'll cover because the type of mutation can have a significant effect on the course of Alport syndrome in men with X-linked disease. I think at this point, we would say that a person with a COL4A5 mutation who has blood in the urine, without any other explanation for blood in the urine, has Alport syndrome. There may be people who will be at a far advanced age before they develop end-stage renal disease. We're talking about men now. But we'd still say they have Alport syndrome.
Great. Are you aware of any research with the CLOTHA gene and Alport syndrome?
With CLOTHA?
Sorry.
No. Not specifically. I can't say for sure that CLOTHA hasn't been looked at in some models, but off the top of my head, no.
All right. How do we educate doctors in a third world country who have never heard of Alport syndrome? Can we ask a doctor from my country to contact Dr. Kashtan on how to evaluate and treat a patient with Alport?
Of course. Of Of course, and I've communicated with a number of physicians and, really all over the world. And yeah, I'd be happy to do that.
Okay, I'm going to unmute all of the lines now. We have one question left that came in on chat, but if anybody has any questions, you can ask them. The
conference has been unmuted.
The remaining question is about a specific treatment for Sonia's son, and if the person who asked is on the phone, I may ask you to ask the question specifically about the medication.
I can see the question.
Okay, great.
And this does look like appropriate treatment. So many people with that level of urine protein will retain sodium. It's part of the physiology of high-grade proteinuria. So a diuretic like furosemide would be common. It also Gesundheit. Sorry. Happens to the best. And furosemide contributes to the management of hypertension also by increasing the elimination of salts. The ramipril helps with blood pressure and proteinuria, and as you said, the anti-fibrotic effects of ramipril. He's also getting spironolactone, which is an inhibitor of aldosterone. So he's getting combination therapy. A statin, like a atorvastatin, would be pretty common in an adult patient with substantial proteinuria, whether it's due to Alport syndrome or some other chronic kidney disease, because people with large amounts of protein in the urine often have elevated cholesterol. And as an aside, which I didn't mention, in mice with Alport syndrome, statins have a beneficial effect on lifespan. Not anywhere near as beneficial as ramipril, but it does help. So I'd say your son is getting appropriate treatment.
Great. We have a question. If a mother is considered a spontaneous COL845 mutation with a child diagnosed, should the grandmother, who is asymptomatic except for hearing loss, be tested?
So the grandmother has hearing loss, but she doesn't have blood in the urine?
Correct. Or is asymptomatic?
Well, yeah, it depends what you mean by asymptomatic. So if the grandmother's urine is tested for blood and it's negative, then it raised the question whether she has hearing loss for some other reason. But if the mutation has been identified, and you want to rule out or rule in the grandmother is having the mutation, then the grandmother could be tested for that mutation. Does that make sense?
Yes. We have a question. Alport syndrome, dialysis not until age 45 and a transplant at age 50. 15 years ago and all is good so far. Hearing loss since late 40s, multiple eye surgeries for torn and detached retinas and a macular hole, but all repaired now and are stable for 14 years, 4 kids, 3 adult sons who have never had hematuria or proteinuria. One daughter, age 30, with very slight hematuria since teens, no protein. My mother had hematuria but no symptoms ever. No other family members have had symptoms, including 2 brothers. Does this sound like common X-linked or something different? Should my daughter get genetic testing?
First of all, you're one of those people who developed a macular hole, which is an unusual consequence of the maculopathy. I didn't bring it up because it's unusual. It does happen. This would be consistent with X-linked Alport syndrome.
The conference has been muted. The conference has been unmuted.
Has a mutation. She can undergo genetic testing. One way to approach it, she could just have genetic testing, or you could have genetic testing, and then if you're found to have a mutation, your daughter can be tested for that mutation.
Okay, another question. I am a 45-year-old woman with normal GFR, normal blood pressure, but high protein in my iron.
In your urine?
Or in my urine at 1,600 milligrams. What medications would be appropriate?
I think it would be appropriate for you to be on an ACE inhibitor. The one thing that women who who are menstruating need to know about ACE inhibitors is that ACE inhibitors can cause, and angiotensin receptor blockers can cause serious damage to a developing fetus, because the fetus needs angiotensin II for normal development of the heart. So drugs that interfere with the production of angiotensin II, like ACE inhibitors, drugs that interfere with the action of angiotensin II, like ARBs, angiotensin receptor blockers, cause serious abnormalities of the heart and or the kidneys in a developing fetus. So when we recommend that adolescent female with Alport syndrome go on an ACE inhibitor, we have to have a conversation about sexual activity and preferably contraception, effective contraception such as a birth control pill or IUD. And the same would apply to a woman with Alport syndrome who has not gone through menopause. So that's the caveat, a warning about these inhibitors. But 45-year-old woman with Alport syndrome who has elevated protein level in the urine should be on an ACE inhibitor.
And this is from the same woman. Should I up my ACE dose to as much as can be tolerated?
I'm sorry?
As a housekeeping note, if you aren't asking a question, if you can put your phone or your computer on mute, we would appreciate that. The same woman who asked the question, 45-year-old, about the ACE inhibitors, should I up my dose as much as can be tolerated of ACE inhibitors?
That's a discussion you should have with your nephrologist. In general, that's what we recommend, but for each person, it really requires the management of the nephrologist who's taking care of the person.
All right. Someone had a question. A 4-year-old son, genetic testing came back negative for all 3 has protein 0.3 in the urine. Do you recommend a kidney biopsy?
So it sounds like his doctor suspect a diagnosis of Alport syndrome?
Yes.
because you have Alport syndrome or you carry that diagnosis?
They are suspected.
Kidney biopsy is an option. Our group just discussed a similar situation this morning. Mother has hematuria, had a kidney biopsy as an adult that showed thin glomerular basement membranes, which is common in women with Alport syndrome. And she has a son who has blood and protein in the urine and has had genetic testing, including all 3 genes, and it's negative. So in that child, we did come to a consensus that a kidney biopsy would be helpful. Your child's, specifically, I can't say, but kidney biopsy can be helpful because sometimes it shows another diagnosis, or it can show changes that are characteristic of Alport syndrome.
Okay, a couple more questions here, and then we'll go to the phones. Are there any recommended supplements or vitamins to improve kidney function?
No, other than those that are part of the management of chronic kidney disease. So, for example, vitamin D, many people with chronic kidney disease take vitamin D, or some take iron, but it depends on the specific needs of the patient. Not we don't make generic recommendations about supplements for people with kidney disease.
Okay, and one last question here. At what age will a man reach GFR 30 if proteinuria persists?
I can't really say. Proteinuria, or the amount of proteinuria, is not a very reliable predictor of age at ESRD. And then with Alport syndrome, the genotype, what I was alluding to earlier, the type of mutation that a man has is more reliable as far as predicting end-stage renal disease than the proteinuria. Sometimes family history. And then, it depends on whether or not the person's being treated.
Thank you. Are there any questions on the phone? The phone lines are unmuted, as we've heard. So if anybody has any questions that you'd like to ask directly, please feel free to do so. Oh, we have a couple more that came in online. Can there be different interpretations of a genetic test? Patient has no hearing or eye issues, but hematuria and high proteinuria. Had a biopsy.
I'm not sure I understand the question.
Would the person who asked it like to clarify? Can there be different interpretations of the test, is I guess the question.
Well, there really should be only one interpretation that's accurate. In the genetic testing, especially procedures like next generation sequencing and whole exome sequencing often reveals variants or variations from normal in the sequences of genes. But not all sequencing variations are mutations that cause disease. So whether the disease is Alport syndrome or some other disease, the laboratory that does the genetic testing has to try to interpret the significance of every variant discovered by the testing. So some variants don't cause disease. Many, as a matter of fact, don't cause disease. But other variants have specific features that indicate that they're disease-causing or very highly likely to be disease-causing. So, two experts looking at the results of genetic sequencing should, come to the same conclusion about the interpretation most of the time. There might be situations where people are uncertain of the significance of a variant. And then, the question is, well, could we be missing something else? Should we check for something else? Or sometimes it doesn't really affect treatment because the treatment is currently is based on the stage of kidney disease. Like what, is there elevated levels of protein in the urine or not? That's our indicator for starting treatment with an ACE inhibitor or an angiotensin receptor blocker. We have other treatments that we add because of advancing chronic kidney disease. But right now, we don't have mutation-specific types of treatment. So let's say a boy has blood and protein in the urine and a kidney biopsy that looks like Alport syndrome, but the genetic testing is normal. Doesn't show any mutation in COL4A3, COL4A4, COL4A5. We'd still treat that boy like he has Alport syndrome, meaning he has proteinuria, so we put him on an ACE inhibitor.
Okay.
That makes sense?
Hi.
I think the next question is, our 13-year-old son was recently diagnosed with Alport syndrome, specifically a hemizygous variant in the COL4A5 gene. The genetic report indicated that this variant has not previously been reported in the human genetic mutation database or the broad exact data set. So most of the mutations identified in the COL4A5 gene in people with Alport syndrome are unique to that patient and that patient's family. So the terminology the geneticists use is a private mutation. So, like I said, way at the beginning of the webinar, well over 1,000 mutations in the COL4A5 gene have been identified in people with Alport syndrome, and only a relative handful, have been reported more than once. So most people with Alport syndrome have a mutation that hasn't been reported before. Not everybody, but most people. So your son's situation is common. Now, the geneticist, like I was saying earlier, has to use different specific features of the mutation to try to come to a conclusion about whether that mutation is pathogenic, meaning it causes disease, or it's probably not pathogenic. And there's specific ways of doing that that usually allow for a kind of a clear decision about that mutation.
Great. We have two more questions.
Okay.
Sorry to interrupt.
Oh, is the proteinuria the cause of fibrosis of the kidney? It's one of the potential causes of fibrosis of the kidney. many nephrologists believe that the protein that's filtered or escapes from the glomeruli, the filtering units of the kidney, into the tubules that drain the glomeruli. But the proteinuria that's then taken up by the cells that line those tubules can cause damage to those cells and start a process that leads to fibrosis of the kidney. But proteinuria is probably not the only mechanism for fibrosis of the kidney in Alport syndrome.
And then we have our corticosteroids or cyclosporin recommended in Alport.
No, there's no evidence that corticosteroids are helpful, and based on our understanding of the disease, we wouldn't expect them to be. Cyclosporin is not used by most nephrologists, in part because cyclosporin itself can cause fibrosis of the kidneys, especially when it's given for years. And of course, we use it as a common drug to use to prevent rejection of kidney transplants. And there we accept that potential side effect of cyclosporin because we have to prevent rejection, which is a worse problem than the fibrosis caused by cyclosporin. But in someone with his own kidneys or her own kidneys, that's not an issue. Rejection is not an issue. So most nephrologists avoid cyclosporin and Alport.
Great. Do the medications reduce existing fibrosis or just prevent further damage?
That's another good question. One of the reasons that we recommend early therapy is based on mouse, not only the human studies I showed, but mouse studies that compared early treatment before there was significant fibrosis to later treatment when there was already some fibrosis in the kidneys of the mice with Alport syndrome. Starting therapy when the mice already had some fibrosis was beneficial. It did prolong lifespan, but it was much less effective than starting before there was fibrosis. So that's another reason we recommend treatment before there's fibrosis, which in people with Alport syndrome is before kidney function starts to deteriorate.
Thank you. Do we have any other questions from anyone on the line that you'd like to ask? All right. Well, thank you so much, Dr. Kashtan, for being here. For those of you who are watching this presentation not live and have questions, you can direct them to us at info@alportsyndrome.org, and we will pass them along or answer them if able to. Thank you so much, Dr. Kashtan. This has been incredibly helpful. We greatly appreciate it. We always appreciate your support, but today I know this is very valuable for many of our patients on the line and for those patients who are viewing this later on. We are, as I mentioned, we are planning our next series. Our next presentation will likely be on hearing loss and Alport syndrome, taking place in March, so stay tuned for that. Thank you once again to Global Genes for the financial support to make these presentations possible, and thank you all for attending.
Thank you, and I hope it's been helpful.
Absolutely. Thank you very much, Dr. Kashtan.
Bye-bye.